Module 1. Let's dive right into bleeding, platelet, and endothelial pathologies and anticoagulation reversal. We are constructing your cognitive schema for the USMLE Step 2 CK right now, moving incredibly fast from cellular defects straight through to systemic protocols. Here's the roadmap to lock in our progression. First, thrombocytopenic pathologies, then coagulopathies and cascades. Third, anticoagulation and reversal, and finally, cognitive pitfalls. Module 1. Thrombocytopenic pathologies and mechanistic drivers. We're isolating the microscopic drivers behind isolated low platelets.
All right, first up is ITP, immune thrombocytopenia. Think of this as an acquired hit job where autoantibodies directly target the GP2B/3A receptor on your platelets, basically marking them for splenic destruction. Now, what's the crucial clinical example here? It's that despite all this heavy splenic macrophage activity, you're going to find a palpably normal spleen. For management, you step it up sequentially. Start with corticosteroids to blunt that immune response, and if they're severely bleeding, bring in the IVIG. Now, watch how things escalate into a total systemic crisis with TTP, thrombotic thrombocytopenic purpura. The microscopic villain here is a severe deficiency of the ADMTS13 protease. Without this essential enzyme, these ultra-large von Willebrand factor multimers just float around uncleaved. This sets off a devastating cascade. Platelets start aggregating inappropriately, forming these widespread microthrombi that literally shear passing erythrocytes and cause catastrophic end-organ infarction.
So contrast that immediately with HUS, or hemolytic uremic syndrome. HUS shares that same microangiopathic profile, but the trigger is totally different. We're talking Shiga-like toxin-induced endothelial damage, classically hitting kids after an episode of bloody diarrhea, usually from E. coli O157H7. The crucial pediatric diagnostic triad you absolutely have to know is microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. Notice what's missing. It typically lacks those severe neurologic symptoms we just saw in adult TTP.
Next up is an iatrogenic nightmare, HIT, or heparin-induced thrombocytopenia. This is driven by anti-PF4 antibodies that literally form a complex with heparin. But here's the twist. Instead of just causing bleeding, this complex dangerously activates platelets, leading to paradoxical, life-threatening thrombosis. The emergency directive here is absolute. You stop all heparin products immediately, no exceptions, and you start a non-heparin direct thrombin inhibitor. Think argatroban.
I want you to burn this visual right into your retina. See those fragmented, helmet-shaped cystocytes? That is the pathognomonic conformation of microangiopathic hemolytic anemia. When you spot these on a peripheral smear, it's a massive, blaring clinical alarm. It means erythrocytes are literally being shredded to pieces by intravascular microthrombi, confirming you're dealing with a highly destructive process like TTP or HUS. Okay, time for our first accelerated pattern recognition block. We have got to aggressively differentiate these two. Classic adult TTP drops the rat fan pentad. Renal dysfunction, anemia, thrombocytopenia, fever, and neurologic dysfunction. Contrast that right away with the focused pediatric HUS triad. Rapidly recognizing these clusters? Yeah, it's absolutely paramount, not just for crushing your boards, but for surviving the wards. Let's simulate a high-pressure clinical scenario right now. A 34-year-old female presents with fever, delirium, a severely low platelet count of 18,000, and an elevated creatinine. What is your immediate next step in management? Think about it. The neurologic changes combined with renal failure absolutely scream TTP, and that demands a highly specific emergency intervention. Breaking down the analytical rationale, immediate plasmapheresis is literally the only definitive life-saving maneuver here. Why? Because it dynamically rips out the offending autoantibody while simultaneously replacing that missing Adams TS13 protease. Corticosteroids, they're just an adjunct here, and giving platelets, that is an absolute fatal trap. You are just adding fuel to the microthrombi fire. Module 2, coagulopathies and consumptive cascade separation. We're zooming out from the cellular level to tackle secondary hemostasis defects. Notice the stark contrast between these bleeding profiles. Hemophilia A and B, driven by factor 8 and 9 deficiencies respectively, trigger deep joint hemorrhages, known as hemarthrosis. You'll see an isolated prolonged PTT, but crucially a normal bleeding time.
On the flip side, von Willebrand disease drives mucosal platelet-type bleeding due to a qualitative or quantitative VWF defect. This elevates both the bleeding time and the PTT, and management is a totally different ballgame. You'll use desmopressin or DDAVP to force the release of stored VWF from the endothelium.
Disseminated intravascular coagulation, or DIC, maps as total systemic chaos. It's a massive consumptive coagulopathy. The simultaneous consumption of platelets and clotting factors causes your patient to bleed and clot at the exact same time. Your systemic laboratory profile is going to be universally deranged. We're talking prolonged PT and PTT, profound thrombocytopenia, exhausted low fibrinogen levels, and a highly elevated D-dimer from all that fibrin breakdown.
All right, this next vignette tests a foundational diagnostic pivot. A patient presents with a prolonged PTT, but when you perform a one-to-one mixing study with normal plasma, the PTT fails to correct. So what exactly is the underlying pathophysiology at play here? Here's the advanced mixing study rationale. It comes down to pure logic. Adding normal plasma easily replaces missing factors, so it corrects a simple deficiency like hemophilia. But a failure to correct, that implies a circulating acquired factor inhibitor. It means there's an active autoimmune assault neutralizing the cascade, and it doesn't care how much functional plasma you add. Module 3, Clinical Anticoagulation Management, Bridging and Emergency Reversal. Shifting gears from pathology to pharmacology. You've got to commit these divergent monitoring parameters to memory. Unfractionated heparin, it requires strict PTT tracking and is reliably reversed with protamine. Low molecular weight heparin, or LMWH, acts differently. It's monitored via anti-XA levels and is heavily dependent on renal clearance. That makes it incredibly dangerous in severe acute kidney injury, so watch out for that.
This brings us to a sequence that is tested constantly: mandatory warfarin bridging. Here's how it works. Warfarin administration rapidly depletes the anticoagulant protein CNS way before it knocks out the procoagulant factors like 279 and X. This mismatch induces a transient, paradoxical hypercoagulable state. Because of this, immediate therapeutic heparin coverage is strictly required. If you don't bridge, you risk devastating thrombotic complications like skin necrosis. Moving to DOAC parameters and emergency reversals. These antidote pairings are absolute non-negotiable knowledge for acute hemorrhage management. Factor XA inhibitors like apixaban and rivaroxaban are directly reversed with andexanet alpha. Dabigatran, which is a direct thrombin inhibitor, has a highly specific reversal agent, idarosuzumab.
Let's test this in an emergency context. A patient on therapeutic warfarin presents with an acute intracranial hemorrhage and an INR of 4.5. What is the precise rapid sequence reversal? In a catastrophic scenario like this, delayed interventions are fatal. You have to identify the absolute fastest method to restore those vitamin K-dependent clotting factors. The acute warfarin reversal rationale is clear. The correct protocol requires immediately administering prothrombin complex concentrate, or PCC, for instant factor replacement. Yes, vitamin K is essential for restoring long-term hepatic synthesis, but it has a delayed onset of hours to days. You must deliver PCC instantly to stop the bleeding and pair it with vitamin K to sustain that reversal.
Module 4, High-Yield Cognitive Pitfalls and Targeted Remediation. Let's expose and eradicate those classic test day traps.
Do not fall for these highly engineered board traps. Trap 1, ruling out ITP because the spleen is palpably normal on exam. Remember, ITP inherently presents with a normal-sized spleen. If it's enlarged, you're looking at a completely different etiology, like leukemia or portal hypertension. Trap 2, failing to recognize vitamin K deficiency in patients with chronic malabsorption or prolonged broad-spectrum antibiotic use. The gut microbiome is critical for vitamin K synthesis, so your clinical suspicion should be exceptionally high in these patient cohorts. This brings us to the absolute most critical, blaring clinical alarm of this entire explainer. Never administer platelet transfusions to an undiagnosed microangiopathic hemolytic anemia patient, specifically those with TTP. Feeding fresh platelets into a TTP microthrombized storm will massively accelerate widespread end-organ infarction. It is practically guaranteeing a fatal outcome. Just don't do it.
We'll end on this definitive diagnostic challenge. When you're faced with chaotic laboratory values, schistotoids on a smear, and systemic hemorrhage, how will you systematically differentiate a consumptive collapse like DIC from a destructive immune response like TTP or ITP? Master this distinction. Anchor these cascade mechanisms to your diagnostic protocols, and you won't just pass your boards. You are going to absolutely dominate hemostasis on the wards. So are you ready to apply the schema to your next clinical vignette?